Hey everybody, my name is Dinah Houston and I'm a neurosurgical ICU nurse here on the unit. This course is meant for new nurses to the neuro ICU without prior ICU experience. Goals for this course are to find the similarities and differences of seizures, epilepsy, and status epilepticus, what their treatments and plan of care are with each of them, and by the end of this course we'll be able to identify the differences between seizures, epilepsy, and status epilepticus, list at least 4 medications used and their purposes, and what the non-pharmacologic or nursing interventions are. So seizures are, in simple terms, an electrical brainstorm. The sciencey way to say it would be neurological dysfunction related to abnormal and excessive discharge of neurons. Building on top of seizures, we look at epilepsy. We take into account what is causing the seizures and the occurrence of the seizures. For example, if you have one seizure from an infection, are you likely to have another one in the next 10 years? Did we have 2 or more seizures from alcohol withdrawal? It's also important to rule out any psychiatric disorders such as conversion disorder when we diagnose epilepsy. There are several types of seizures. We break them down into 2 basic groups, generalized and focal. Generalized is then broken up into convulsive. It's the more stereotypical movie style seizure with muscle jerking and loss of consciousness. Generalized non-convulsive is just that, non-convulsive. The patient either goes completely stiff or completely flaccid, and they also have loss of consciousness. Often the patient will fall during these types of seizures. It's also important to know what a post-ictal state is. Post-ictal is an altered level of consciousness after a seizure. Each patient will have a different time, how it affects them. It also is dependent on the type of seizure and how long that seizure was. Focal seizures happen in a more focused part of the brain, hence the word focal. The portion of the brain that is affected is directly related to what portion of the body is affected in the seizure. Simple focal seizures have more muscle twitches, auditory or visual hallucinations, vertigo, numbness, just to name a few. There's a whole long list. With a complex focal seizure, there's more impaired consciousness, but it's not a total loss of consciousness as in the generalized seizures. They may continue doing what they're doing, but it's more uncoordinated. They stare off into space, and they may not answer questions when you speak to them. So what is status epilepticus or status or SE? It's a medical emergency. Seizures that last longer than 5 minutes or back-to-back seizures without returning to baseline. And of course, these are different types of status, convulsive and non-convulsive. That's pretty self-explanatory. Refractory happens when we try to treat the seizure with Ativan and an AED like Keppra, and it persists. Don't worry, the medications are coming up. Super refractory status persists longer than 24 hours. So what causes status? Stroke, intracranial hemorrhage, brain tumors, metabolic disturbances, drugs or alcohol abuse, subtherapeutic levels of anti-epileptic drugs. So say you forget to take your Keppra for a week. So basically what I'm saying is all of our neuro ICU patients are at risk for having seizures and status. Pharmacological treatments, the most important medication to know for seizures is Ativan. We use this to stop a seizure. It's not meant to prevent seizures. That's where the anti-epileptic drugs or the AEDs come in. There are over 20 AEDs in use, so these are just a few that you see here on our unit. For status, we will sedate the patients while giving them AEDs to try to control the seizures. Most commonly used on this unit are Versed, Pentobarb, and Propofol. These can be combined or used individually based on their EEG readings. So we can learn about these medications more in detail. We're going to break everybody into smaller groups, and you guys are going to present some medications to the larger group. It's going to take about 15 minutes for you guys to put the information together. We'll get you some poster board and some markers. Short presentation, no longer than 2 minutes. Make sure you include the drug class, what we use it for, how we give it, dosages, side effects, and essential things we need to monitor, whether it's labs or vital signs or drug interactions. Considerations for status. Remember your ABCs: airway, breathing, circulation. This is one of the reasons we sedate patients who are in status. They will be intubated on a ventilator. Because of the sedation, they may have hypotension that we'll need to treat with pressors. Care is the same for all intubated patients. We turn them, we do oral care, we do the VAP protocols, we do skin protection, we bathe them once a night. All patients sedated for status will be on a continuous EEG monitor. We use this to titrate their sedation based on their waveform and try to achieve what's called burst suppression. Once a patient has been seizure-free for about 24 hours, we'll start to back the sedation off slowly and watch for any return of seizure activity. If seizures start to reoccur, then we turn that sedation back on or back up, and then we try again later. Non-pharmacologic interventions or basic nursing interventions. For all patients, whether they have a risk or a history of seizures, we want to make sure their side rails are padded. This protects their head, keeps them from getting limbs caught in places. We want to make sure that suction is set up in the room, not just the packages, not just a yonker on a tube. We want to make sure the canister's set up, it's hooked up to the wall, it's readily available, it's turned on. We don't want to have to be fumbling with this while a patient's having a seizure. During a seizure, look at the time. We want to know how long the seizure is lasting. Call for assistance. Do not leave your patient alone. Protect their head. Or is their head banging on a side rail we forgot to pad? Is it hitting the floor? Did they fall from a chair, fall out of bed? Do we need to put them on any O2 or is their SATs dropping? These are all important things. And please, please, please do not put anything in their mouth. Don't think you're going to pull their mouth open to keep them from biting their tongue, or they're not going to swallow their tongue. These are all old wives' tales, things you learn from movies, and these are not appropriate. For patients who are in status, we want to keep them in low stimulation, turn the lights off, limit the visitors, keep it very quiet. Don't leave the TV blaring on Jerry Springer or anything crazy like that. Sometimes if we're having trouble controlling their seizures, we'll try to put them on a cooling blanket for induced hypothermia, try to do 96 degrees and maintain that. And sometimes we'll change their diet to a ketogenic diet. We'll special tube feeds that we'll order, and we'll be giving that and checking frequent blood sugars and urine ketones to follow that. So now we're going to do a case study as a group. Amelia, she's 34, is admitted to the ER via ambulance. EMT said that she was found down seizing by her husband. She had a second seizure en route lasting about a minute and a half and was given 2 milligrams of Ativan. In the ER, she's drowsy but oriented, moving all extremities with stable vital signs. What do we need to do to her room to prepare for her? So that's going to be setting up suction and patting her side rails. What orders would you expect to see for this patient? This is going to include basic labs, medications like Ativan, Keppra, Dilantin, something, an AED, urinalysis, drug screening, things like that, so we can try to determine what's causing that seizure. So Amelia's still in the ER 4 hours later, not surprised. She's waiting for a room on the med-surg unit when she seizes again with you at the bedside. She's unconscious, all limbs are stiff, and she has bitten her tongue. What do you do? So what are we going to do? We're going to call for help. We're going to pay attention to the time. We're going to protect her head. Somebody's going to grab some Ativan and give her some Ativan. You notice that the seizure is starting to last 5 minutes, 15 seconds. She's received 2 milligrams of Ativan, like we said, during the seizure, and she was giving a loading dose of Keppra when she first got to the ER. So what should happen next? Well, this is your ABCs: airway, breathing, circulation. We're going to intubate her, get her sedated, get her up to the unit. Right, and this is just some of the references that we used for this presentation and handouts. If you have any questions, We can go over them now, or you can ask on the unit. Ask anybody on the unit. They'll be happy to help you out. If you see somebody with an EEG in their room, go in, check it out, and kind of get yourself familiar with everything.